Hiya ladies, thank you again. Thursday night, here we are. All things menopause and peri-menopause and all of that. You'll be pleased to know I'm not talking about my vagina tonight, because I know I normally do. Every week I tell you a little story about my bits and bobs. So tonight we've got Professor Chris Harden is coming to talk about urology and all things urology. So let's give him a welcome.
Right, so my name's Chris Harding. I'm Professor of Urology in Newcastle, but I also live in Sedgefield. And I was really pleased to see this group being formed and set up, because it's a real Cinderella area, as a lot of female medicine tends to be, sadly. But let's see if we can't change that. So what I'm going to talk about tonight are two main things that I see in peri-postmenopausal women. And the first one is urinary tract infection, and the second one is urinary incontinence. So the first thing about urinary incontinence is it's not just a single entity. So there are different mechanisms that cause urinary incontinence, and about 90% of all incontinence would be covered by these two main subtypes here. So one is stress incontinence, and it's got nothing to do with you being stressed or anxious or anything like that. What that is leakage of urine when you raise your abdominal pressure. So when you cough, when you sneeze, when you run upstairs. When trampolines were very prominent and all the kids wanted trampolines, all the mums were coming to me realising they had stress incontinence, because those kind of forces on the pelvis lead to stress incontinence. And that's because really the water pipe, the urethra and the neck of the bladder become very mobile, because you lose support. As you lose estrogen, a lot of your pelvic ligaments slacken a little bit, you lose a bit of support, and this is the similar mechanism that will underlie prolapse. So when you get the bladder which is not supported and you then put pressure on it from the top end, it will move, and I'll show you an example of that in a little while. So that's stress incontinence. So the next subtype is urge incontinence. And urge incontinence is, I need to pee, oh, I haven't made it. So it's incontinence which is preceded often by a feeling of urgency. Now that urgency, which is a really sudden desire to pee, that's what urgency is, that can last a second, 2 seconds, and then you've leaked. And so that's another subtype. And that's really one feature of something that you might have heard of called overactive bladder syndrome. So I must just put this little disclaimer here, is that not all postmenopausal women get these symptoms, okay? But if this is relevant to you, then you might find the next 45-50 minutes quite interesting and informative. Now it really is a Cinderella topic. So I just pulled this off the internet a couple of days ago. This is Menopause Matters, big support group. I think it may be American by some of the wording that's used. And it lists the top 40 menopausal symptoms. Now I can't see UTI on that. And that's the single biggest thing I see associated with menopause. So that's a real problem area. And I think with a bit of education, it's often not difficult to get on top of urinary tract infection. So that's the first thing I'm going to talk about tonight, is urinary tract infection. So this is the female urogenital tract, as we medics call it, but in essence it's the genitals and the urinary tract combined. And there's a couple of things that I want you to notice, okay? So the first thing is the proximity of the uterus, the womb, to the bladder. Okay, and when a bladder is not full, the womb will flop over and sit on top of it in most cases, and that puts a bit of weight on the bladder, and this is the stress incontinence thing I was talking about. The second thing is where the bladder is situated in relation to the vagina. So the vagina is here, but as you can see, the bladder is in front of it. And the water pipe, which is called the urethra, that will insert on the front wall of the vagina. So any prolapse of the vagina will kink the water pipe. Right? And that can have a number of different effects. You all know what happens when you kink a hose pipe and suddenly there's no water coming through. So you can actually go the other way. So as well as incontinent, you can have problems with urinary retention as a result of prolapse. So there's lots of different mechanisms. And this diagram down here shows exactly what you'll see in terms of vaginal anatomy. So it's well below the clitoris there, and it's just above the vaginal opening. This is the front wall of the vagina, and this is where the urethra, the water pipe, opens. So now that we know the roadmap, and something else that's quite interesting is obviously the tubes and ovaries are intertwined with the tubes that are in the urinary tract, so it's all really linked. And actually, in womb, they're all formed from a similar kind of, what we call embryology, a similar kind of cell. So very often, urologists like me do little bits with gynecology, and gynecologists do a little bit of urology, and this is where the kind of crossover of the two specialities happens. So what is a urinary tract infection? What do people think we mean when we say urinary tract infection? And the most common mistake is, oh, it's bacteria, isn't it? Bacteria in your urine. Well, it's not. There's a lot of people, especially elderly people, that walk around absolutely happily with bacteria in their urine. Okay? A urinary tract infection is your body's response to the bacteria in the urine. So sometimes when there's bacteria in the urine, you won't get any symptoms at all, and that's fine, and I wouldn't ever treat that. But when you're getting symptoms that are reflection of urine in the bacteria in the urine, then that's a urinary tract infection. Okay? So just demonstrating bacteria or not on a urine sample is really neither here nor there for me. And this is relevant to you because you might present with, I've got urinary tract infection. You go to your GP, you pee in a bottle and take it, and then GP will store it, and it might sit in the fridge for a day, and then the van comes around at tea time, then it goes to the lab, but of course the lab staff have left, so overnight it sits in a incubator, and then the next morning some poor lab technician is going to try and extract some bacteria from this. Well, good luck with that, because you will often find the GP saying, oh no, there's no bacteria in you, you can't have had a urinary tract infection. It's all, urinary tract infection is all about symptoms, okay, and that we're moving right away from believing that the bladder should be sterile. So when I was a medical student, the teaching was there's no bacteria in the bladder, it's a sterile environment. We know now that's absolute rubbish. There are 30, 40 different types of bacteria in all of our bladders. Some of them cause a lot of trouble and others actually help. So a urinary tract infection, just to be clear, is symptoms, irrespective of what your tests show. So what is cystitis? Is cystitis the same? Well, it kind of is. Anything with itis on the end means inflammation. So appendicitis is inflammation of your appendix and normally results in you having an appendectomy. This is inflammation of your bladder, and there's not just bacteria that cause that. So, for instance, we have in the last 10 years seen the rise of a recreational drug called ketamine, which was first sort of given as like a horse tranquilizer by vets, but people are abusing it recreationally. That causes really, really bad cystitis, but that's nothing to do with infection. So cystitis is inflammation of the bladder, okay? So in terms of UTI, I said it's all about symptoms. What are the symptoms? Well, you might go more frequently. So you know, the average frequency might be 6 or 8 times a day. That's normal, okay? It may or may not be normal to get up once at night. It's definitely not normal to get up 2 and 3 and 4 times a night, okay? So that's abnormal. You may get something called urgency, which, as I said, is a really sudden desire. You can't hold it. You want to pee. You might think you're desperate. You'll sit on the toilet and you'll do a thimbleful. And that's a classic UTI type symptom. The absolute hallmark of urinary tract infection, however, is something medics call dysuria, which in effect is just pain when you pee, like passing razor blades. I've heard it a million times. You might also find that the presence of urinary tract infection will make you get up when you normally sleep through. So all of those kind of things, you might even get urinary leakage that you don't normally suffer from. So all of those symptoms, these transient symptoms, i.e. symptoms that are very short-lived or very acute in onset, might just suggest that you have a urinary tract infection. And you might respond to antibiotics, and you might have a test that said there was no bacteria in your urine. If you've responded to antibiotics and your symptoms have gone away, you've had a UTI. I don't care what anyone says. That is a fact. Antibiotics do nothing else other than kill bacteria. So it's really important that we stress yet again, it's my hobby horse, so I apologise, but that UTI diagnosis is symptom-based. So what are the risk factors for it? And indeed, where do these bacteria come from? Do they come from the air? Do they come from our partner's genitals? Not really, they come from you yourself. So the most common bacteria that causes a urinary tract infection is called E. coli. Now you'll have heard about it from when you get these scandals in butcher shops that don't keep the meat right. And E. coli can be very, very damaging. But everyone sat in this room has got plenty of E. coli in their bowel at the moment, and it's doing a really good job to help us digest. But it's just when it relocates to the urinary tract, not a good option. And its passing point in the high proportion of cases is the vagina. If the vagina is colonized with E. coli, that's generally bad news, because it only takes a very short journey to go from vagina up to water pipe into bladder. In severe cases where it's untreated, it can go up to the kidneys and cause something we call pyelonephritis. In very, very severe cases, it can cause sepsis. So, this is it's not an insignificant disease, as urinary tract infection. The vast majority will have an uncomplicated cystitis, an inflamed bladder because of bacteria. They'll take 3 days or 5 days of antibiotics and they'll get better. But, I've got patients under me at the moment in Newcastle who are on intensive care with urinary tract sepsis, which I'm sure started with an infective cystitis. Have I been talking too long? So risk factors. Being perimenopausal is a big, big risk factor, okay? In your 20s, 30s, your vagina was dominated by a bacteria called lactobacilli. Lactobacilli is a really good protective, non-harmful bacteria, okay? This is where your probiotics are coming in, okay? And we'll talk about them a bit later. Now, lactobacilli love moist, warm conditions. So and conditions that are quite acidic, and your vagina is quite acidic when you're younger. As you get towards and through the menopause, your vagina becomes less moist, it's dry. You've probably talked about that quite a lot in the group. And when that happens and there's a change of conditions, the E. coli leap on that. So they think, all right, we'll set up camp here because it's now conditions we like, it's less acid. And when the E. coli colonize your vagina, then that can be an issue, and that's how you can get recurrent infections. Now, this is the underlying basis for vaginal treatments for recurrent UTIs, which we'll talk about in a second. So, it's really common. Lifetime incidence of urinary tract infection is at least 50%, so at least half of you sat in this room will have had a UTI at some point in your life, probably more. My personal belief is that's near to 80%. There's not many women who've gone through their lives without ever having a urinary tract infection. And it's got 2 peaks of prevalence, which underlies another risk factor, which is intercourse. So sexually active young females get recurrent UTIs. We have a condition that we call honeymoon cystitis. And that basically reflects that sexual activity is a risk factor. Perimenopausal women get it, and they get it because the vaginal conditions change, and the vaginal bacteria change from lactobacilli, which are great, to E. coli, which are not so great. And E. coli will account for 3 in every 4 urinary tract infections, so it's the most common urinary tract bacteria. And as I've said, the reservoirs of the bacteria are in the rectum, where E. coli is doing a great job, helping us digest stuff and make stools, and the vagina, where it's not so good. And this is what an E. coli looks like. So this is one single E. coli. Now, when you get a urinary tract infection, you will have like 100,000 of these in your bladder. And E. coli is really good. And the fact that it's still around shows you just how good it is, because, if we've been on the earth for that length of time, the human race, E. coli has been on the earth for that length of time. So it's, we're not going to win this. We're not going to win this battle. We have to just contend and just basically hold our position. 2 features of E. coli that make it really good are these things. These are called flagellae, and there's little tails which make the E. coli swim. It's really good because if it's in the bladder, it can swim up to the kidney, and then before you know it, it can really take a hold. But the single most important thing that an E. coli possesses are these little spikes called fimbriae, and they attach to the lining of your urinary tract. So once this gets up your urethra and into your bladder, it's going to go looking for the bladder wall, and it'll stick on it, and it'll burrow in. Because E. coli are really no good without a cell. So those lining cells are great. And what will happen when you're fighting this with your own immune system? So before antibiotics, UTIs didn't kill everyone. So we have an immune system. That's something that we've got to remember. And the immune system will shed these cells where an E. coli is stuck to them. And that's when you sometimes get cloudy urine. because it's full of this debris, which is like cells. But what these fimbriae do is they stop the kind of flushing action of us making urine and peeing 6 times a day from eradicating it. If that was enough, that's why you drink more. You drink more when you have a urinary tract infection. That's entirely the right thing to do because you're trying to flush it all out. But it's like these are like the little super glue of the bacteria. So that makes them quite adherent and quite difficult to eradicate. So, is it bad? Is it bad if you get a UTI? Do you need tests? Have you got cancer? Is there something else going wrong? Well, actually, no, in the vast majority. So, I run a UTI clinic at Freeman, which basically takes the difficult UTIs for the north of England. And I think when we last looked at our numbers, about 1 or 2 in every 100 had anything at all wrong with their urinary tract in terms of structure or function. So the vast majority of UTIs or recurrent UTIs occur in normal urinary tracts. So there's nothing wrong with your bladder, there's nothing wrong with your kidneys. So really, what tests do you need? Well, your symptoms are enough as far as I'm concerned. What's useful is if your GP or a walk-in centre would send a sample, because if you come back to me at 3 or 5 days, say I've took those antibiotics and I'm not getting any better, and I'm starting to get a bit of a temperature, and actually the pain there's now a bit there, and I'm a bit worried, then if I've got a urine sample in a lab demonstrating a bacteria to guide me what antibiotics to give, then that's great. But that doesn't come for 2 or 3 days. So when I see you first off and you present with all these symptoms we've talked about, then I'll give you an antibiotic, but it'll be a guess, right? And the guess will be, it will likely be E. coli, because that's 3 in every 4 infections, and E. coli are generally responsive to 3 or 4 different antibiotics, so that's a best guess. And if you're not responding, then the first thing I'll do is think, did we send a test on the day, and what does it show? Is it resistant? So I'm going to talk a little bit about antibiotic resistance in a second, because that's a really big problem. And this is why I'm going to highlight the range of treatments to prevent recurrent infections. It's not all about antibiotics. Just a couple of examples of things that can cause recurrent urinary tract infections. Okay, so this white thing here is an absolute cast of the inside of a kidney. That's what the inside of a kidney looks like. So if you've ever made steak and kidney pie and cut the kidney down the middle, you'll see that there's actually like a load of little funnels interconnecting. Yeah? Never eat steak and kidney pie again, will you? So this is called a staghorn stone. So this is a massive kidney stone which is filling the whole kidney. So sometimes we see that. I might see 1 or 2 of those a year in association with recurrent UTIs. So this is rare, okay? That's a bladder cancer. This is me in a bladder with a camera, and that's a little bladder cancer. It looks like a little cauliflower. I probably see 2 or 3 of those a year in association with urinary tract infections, and I must see hundreds and hundreds and hundreds of urinary tract infections every year, okay? This is a scan of a bladder, okay? And on an ultrasound scan, fluid comes up black, okay? So this bladder is pretty full. I think you can all see that. This is after this woman's peed. So she's gone for a pee, feels she's empty. I've put the scanner on and there's a pint in there. Stagnant urine is a real risk factor for urinary tract infections. If you've ever left water in a vase too long, you know what stagnant fluid can do, right? This is not just water, this is protein. This has got everything bacteria love, your urine, everything. And so, stagnant urine is a big, big risk factor. The other thing stagnant urine is a risk factor for is stones. So you can get stones in the bladder. But in the main, 90-odd% of you won't have any of this. So you will have normal urinary tracts. But that doesn't make you better, just to know that. So in terms of tests, I will routinely do an ultrasound scan of the kidneys and the bladder, and that will include scanning the bladder after you've peed to see if you're empty. And if you're over 45, I'd put a camera in just to make sure, because you're in the kind of at-risk group for bladder cancer. So I just have to, because of course one of the cardinal symptoms of urinary tract infection is passing blood, but it's also a cardinal symptom of bladder cancer. So you kind of do, if you're getting recurrent infections, you probably do need that just checking out. If you've only ever passed blood at the time when you had a urinary tract infection, then you don't need to have any of these tests. But, that's just to say that not all urinary symptoms equal urinary tract infection. So, what's recurrent UTI? Well, recurrent UTI is 2 episodes in a 6-month period or 3 in a year. And that is a widely accepted definition of recurrent UTI. If you've got recurrent UTI, then you should probably be talking to your doctor about how you can prevent it. You should probably be coming to see somebody like me and getting a scan and maybe a cystoscopy if you're of the right age group. And this is important because about 1 in 4 women, now I told you just a second ago that half of you at least, probably nearer 75-80%, will have had a UTI in your lifetime, yeah? A quarter of those women who've had a UTI will go on to develop this recurrent picture, so 2 in 6 months, 3 in a year. And if you've had a urinary tract infection, you'll know how bad the symptoms are. You can't go to work. You can't actually be about 3 meters away from a toilet. You know, you cannot work. This is a big, big quality of life effect. So, you know, it's an important thing. But, there, you know, I've been a bit gloomy. Effective preventative treatments are out there and there's lots of them. But you've got to be a little bit careful when you're looking at the evidence. And the reason I put this on was to remind me that a lot of the clinical trials that show cranberry supplements to be effective are sponsored by this company, you know, who actually sell cranberry products. So just be a little bit circumspect when you're looking at these evidence and these claims. And, you know, I regularly get patients coming up to see me and show me something that's in the Daily Mail or something else. And, oh, look at this trial. And you've got to be a little bit critical. So if, for instance, I've said, look, I've just developed this liquid and this liquid will cure UTIs, right? The best way of testing it is to give this liquid to half of you at random, chosen randomly, to give a liquid that looks exactly the same to the other half and watch you for a period of time. And that, in effect, is called a double-blind randomized trial. And that's the most effective way of demonstrating any kind of success in terms of medical treatment. It is not 99% of people think they like the taste and they've got less UTIs. You know, there is a robust way of demonstrating effect. Okay, so we have actually got a full house in terms of preventative treatments with regards to UTIs. So let's start with antibiotics, okay? We call them prophylactic antibiotics, and all prophylactic means in medicine is it prevents something. Okay, so these are preventative antibiotics. So these will be typically a low dose of an antibiotic taken every day for anywhere between 3 and 12 months, or even longer in some cases, especially children. So this, you take a daily antibiotic, okay? And these are very effective, probably the gold standard in terms of prevention. So if you want to shoot for the biggest target and make sure your symptoms get under control, you should think about a daily low-dose antibiotic. Another way we use antibiotics to treat UTIs when people are getting them recurrently is to give something called, I think people now are starting to call them rescue packs. So it's, in effect, it's self-start treatment. So you might have a 5-day course of an antibiotic in the bathroom cabinet ready for, because UTIs only happen on Friday night, you know, when the GPs are shut and the walk-in centre's busy. So you might have that in the bathroom cabinet, okay, and then you're ready to go. And this early treatment stops this ascension that I was talking about. So what I was talking about, it starts with cystitis, and then it might ascend to the kidney, and then, you know, for those who are very unfortunate, it could end up in sepsis. So getting onto it quickly will actually, via self-start therapy, because you know, you try and phone the GPs tomorrow morning, right? First of all, good luck. And secondly, how long will you hang on for? And we've got good GPs in this village, I think. But they're just so busy. They're just so busy. So firstly, you report. Then they might want a sample. And then, you know, oh, the doctor will have to write a prescription. It might be the end of the day. By which kind this bacteria has been expanding, expanding, and expanding. A good example of that is if I set optimum conditions in this room for bacterial growth and reproduction, that one little E. coli, where you'd fit about 1,000 on a pinhead, the bacterial population would fill this room within about 12 hours. So bacteria are brilliant at reproducing, absolutely brilliant. So that's antibiotics. Okay, and I don't want to say too much, go into too much detail about antibiotics. So this is a slide that I'm really loath to get rid of, especially in modern times. So this is the World Economic Forum. So this is like the movers and the shakers of the world. And they sit down once a year and they look at what is a risk to society, what's going to bring the world to a sudden crash. And as you can see, in the center of this are things like global governance failure. Yeah, so like revolutions and all the rest of it. But they've included antibiotic-resistant bacteria as a global threat, because it is. And the reason I don't want to get rid of it is because it's just next to this little word here called pandemic, which we knew nothing about when these sat in 2014, but we know all about sadly now. So they, in 2014, thought the threat of a pandemic was about the same size as the threat of antimicrobial resistance. Well, we've had a pandemic. So we're going to go back now, and we're going to talk about what you can do in a non-antibiotic way. So these are the things you can do to try and reduce your risk of antimicrobial resistance. And the reason antimicrobial resistance and antibiotic ingestion are so closely related is if you imagine you've got 100 E. coli, right? And trimethoprim, the most common UTI antibiotic, that would kill about 70 of them. So you take your trimethoprim, 70% of your E. coli in your blood get wiped out. The 30% live on and reproduce and reproduce. And now you've got a population of trimethoprim resistant. So you take a second antibiotic, let's say nitrofurantoin, yeah? And that might kill 90% of them, but the 10% that's left. And that's a very simplified way of talking about antimicrobial resistance, but that is the issue. I am worried that in my career, and I haven't got long left to practice, probably about another 11, 12 years if I'm lucky, I am worried that in my career I'm going to be faced with a patient who's got a UTI and I'm going to say it's over to you and your immune system because I don't have an antibiotic that's going to fix you. And there's reports from America and the Indian subcontinent of multi-resistant bacteria. So this is not, this is why the World Economic Forum are bothered. So really, non-antibiotic options, that's probably where it's at, because they don't breed resistance. They will universally allow you to eradicate all bacteria, whether it's sensitive to an antibiotic or it isn't. So the easy thing is fluid intake. So there's a great trial done in the States where what they did is they got UTI sufferers and they randomized them to a group who just carried on and got a little leaflet about drinking more water. Because everyone drinks enough water, don't they? I don't know anyone gets a UTI, because you ask any patient, oh yeah, drink loads. Yeah? But sadly not. Because on a day like today, how much fluid do you think you've lost just through sweating and breathing? Plenty. Maybe half a litre? Have you drank an extra half a litre today? I haven't. So, this lack of hydration and lack of the flushing action is allowing them E. coli to stick onto that lining of your bladder and not get flushed out. So anyway, the trial in America, a leaflet to one half of the population, 2 bottles of Evian on your doorstep every morning to the other half. And the reduction in UTIs was tremendous. And they actually looked at the colour and the strength of the urine in the Evian group to make sure they were drinking it. A lovely study which just basically proves what we all knew, that drinking water reduces your risk of infection. Okay? Cranberry products, they do actually do something. Okay, the evidence is a little bit patchy. So cranberry have got this, within cranberry there's this little molecule that fits lovely on the fimbria of E. coli, those little spiky supergluey type things. So the cranberry binds the E. coli in the urine and then you pee it out as a complex. So it stops the superglue from sticking to the lining of your bladder. So there is something in cranberry. The evidence is not brilliant, so it's not an amazing treatment, but I have several patients who absolutely swear by it and think, so if that's for you. We don't know whether it's best taken in juice, tablet, extract, whatever, because they haven't done the trials. But in effect, cranberry is one. So some of the things that might be really pertinent to this group are topical estrogens. And by topical estrogens, I mean an estrogen-based cream or pessary that you put inside the vagina. So how does that work? Well, what estrogen does is it improves the blood supply of the vagina, makes it more moist. All those things, those lactobacilli, those nice bacteria that I was telling you about earlier, they like. Okay? And that, when the lactobacilli overgrow, they produce a lot of acid, and E. coli hate acid. So the E. coli will die off. So that's one way of repopulating your vagina with good protective bacteria and getting rid of the nasty E. coli. And E. coli, like I said, it's only nasty if it's in the wrong place, because it does a great job in the bowel. So that's what topical estrogen is. You can get it in cream form. A lot of women don't like sort of applying it inside the vagina themselves, and I can get that. So it comes in like a pessary form as well, with an applicator, and that's like it's like a little tablet, and it kind of froths up in the vagina. And you would use that every day for a fortnight, and then twice a week thereafter. Okay, and when they've done these randomised trials that I was telling you about, one half got oestrogen and the other half didn't. The oestrogen reduced the urinary tract infection frequency by 85%. So this is a real top-notch treatment. Okay, and to boot, it's licensed for this thing called genitourinary symptom of the menopause, which the cardinal symptom is dryness and itchiness, soreness of the vagina. So win-win. This is something you might not have heard of called methenamine hippurate. It's marketed as Hiprex. We've just published a big trial in the British Medical Journal about 2 months ago that's really changed, well, it's going to change guidelines for urinary tract infection, and it's using this. So what I did is I took 240 women, and 120 of them had Hiprex every day for 12 months, and 120 of them had a daily antibiotic, a low-dose antibiotic, these prophylactic antibiotics I was telling you about at the start. And when these women went into the trial, so they were recruited from 8 centres around the UK, so it's an absolute representative sample of UK women, but it was led by us in Newcastle. So we've got 120 in each arm. When they come into the trial, they are getting, on average, 7 UTIs a year. With the methenamine and with the daily antibiotics, that 7 became about 1, just over 1 in the case of methenamine and just under 1 in the case of the antibiotics. But the effect was so similar, we were the first group that have been able to declare methenamine is not inferior to antibiotics. So if you want a non-antibiotic alternative with proven effect, methenamine, because it's taken you from 7 to 1 in a year. So that's and half of the women in this trial were UTI free throughout the year. So this is a really good treatment. This has been out since the 60s, and I've been using it. And about 5, 6, 7 years ago, someone said, "Oh, I moved down to the southwest. Can I still come and see you in Newcastle?" I said, "Oh, that's a long journey for you." And they said, "Oh, they won't prescribe methenamine for me in the southwest. There's some kind of red flag on it in their local health authority." And I said, "Oh, so I did a bit of digging, and I realised that actually there's a load of health authorities that don't prescribe it because they think it's a risky medication, and I'm not sure why. So I thought, right, let's do a trial and prove it once and for all, and that's what we've done. And that's a free access paper if you want to have a look at it. The trial's called ALTAR, ALTAR. That's a free access paper, and it's got a patient summary in there, so if you want to avoid all the medical jargon, just have a look. British Medical Journal about 2 months ago.
Chris, sorry, can you put a link to that on the paper?
Yes. I say yes. Someone can. Yeah. Okay. The next thing is D-mannose. You may have heard of D-mannose. So that's not a prescription antibiotic. That's just a sugar. So D-mannose is a sugar that you can buy on the internet. And you take 1 gram twice a day. And there was another one of these randomized trials, but this was D-mannose in one arm and daily antibiotics in another. And it did exactly the same. So D-mannose, again, proven treatment. You've got to just be a little bit careful if you're diabetic. Because obviously if you're diabetic, you want to restrict your sugar intake, and it's no good shoveling loads of this down. Vaccines, they're not really vaccines in the sense of like the COVID vaccine. They don't let you mount an antibody response. What they are is they give your immune system a little boost. So they're basically crushed up E. coli, and you can either take them orally, vaginally, or there's a new one out which is a sublingual spray. These are really in the trial phases, so I wouldn't be recommending vaccines. I don't really routinely use them outside of a research trial, but that's something for promise. So all this doom and gloom that we're going to run out of antibiotics and we're all going to die of UTIs, actually we've got a load of things on our side. If all else fails, we can put things into your bladder. So there's 2 main things that go into the bladder. One is something that it's mainly hyaluronic acid. So you've probably seen Cheryl with the face cream, and it's hyaluronic acid, and she's worth it, and all that business. So it's quite expensive, so GPs don't like us recommending it, but it's hyaluronic acid, and what that'll do is that will line your bladder. So in the inside of your bladder, you've got this kind of mucousy lining. That's the best analogy is it's like varnish on wooden garden furniture. When you get an infection, that varnish starts to flake and peel, and the wood underneath will get damaged. i.e. the bladder underneath will get invaded by bacteria. If you can keep that line, that's your first line of defence, or one of your first lines of defence. The other thing I do is I just put antibiotics directly into the bladder. These are for my most severe cases. So I will teach a patient to pass a catheter into her own bladder and instill the antibiotics, and she'll do that once a week for a 6-8 week period. That sounds ghastly, I know. But you've got to remember, these are really end stage patients. So there's a lot to be optimistic about in the field of urinary tract infections. Now, I can either take UTI questions now, or I can just take questions on UTI and incontinence at the end. It's entirely up to you. If anyone's got a burning question about UTIs, I'm happy to answer it. That's a bad pun, wasn't it?
Can I just ask that with those questions
At the end, okay.
Only because it takes them to the days.
Okay, we wouldn't want that. Right, okay, so we're going to talk about urinary incontinence. So I've told you the two main types of stress and urge. And of course you can get mixed. You can get an element of the two. You can get stress, which is the urinary incontinence where you cough and sneeze, and urge, which is preceded by urgency. So this is an x-ray of a female, and you can tell it's a female because she's had her tubes tied, look. And she has had her bladder filled up with a liquid that shows up black on x-ray. This is the pelvis, yeah? See this little thing that looks like a pair of goggles? That's your pelvic bone. And this is where the bladder's sitting in the perfect position, just at the top of the pelvic bone. Okay? I asked this woman to cough and look at where the bladder descends to. So this is, it's gone that far. It's gone, and that's 2 or 3, 4 centimetres. So this is what I was telling you about, the lack of support. This is stress incontinence. Okay? You can also see that some of this fluid start to leak out. So this is stress incontinence demonstrated on an x-ray. Now, sadly, the prevalence of all incontinence increases with age, but it is not normal to leak urine. Do not think, oh, I'm old, it's fine, you know. Which brings me on to my absolute hobby horse. Right. I might get sued for this, mightn't I, if it goes on YouTube, right? Let me tell you what Tenor Lady is not, right? Tenor Lady is not bladder protection in any way, shape or form. Tenor Lady is knicker protection and trouser protection. It is not bladder protection, and that's what they market it, right? These things soak up urine. That is all they do, right? Now that is useful. I'm not playing down their use, because they allow some of my patients to go outside to leave the house. But these will not get you better, right? This is very much a holding measure. So how do we diagnose incontinence? Well, again, it's just what listen to the patient. Listen to what the patient tells you. They will say, every time I go to the gym, I'm soaked, I have to put a pad on. Every time I run up the stairs, when I cough, when I have intercourse. And that could be the most embarrassing thing. Because, of course, because of the proximity of the bladder and the vagina, like I've just showed you at the start, any kind of manipulation of the vagina will put pressure on the bladder, and next thing you know, it's leaking. And that's really, really embarrassing, because that's something that, you know, a lot of women don't even want to share that with their partner. So they just stop doing it. The other thing is, what you want to include is something called a bladder diary. So a bladder diary is basically a piece of paper with a load of times on it. And I get women to fill in when they pee and how much. So as I said to you, peeing is probably about 6-8 times a day. That's normal. It might be normal if you peri-post-menopause and get up once a night, but no more than that. And what a bladder diary also does is quantifies what you're drinking. So I've had a couple of instances of young lads actually come to see me with new onset urinary incontinence. The first thing I do is send them a bladder diary. The first column is what you drink. So you get it set, and I ask them to fill out for 3 days, and you get it back, and it's coffee, tea, Red Bull, Monster, you know, all of these things that stimulate your bladder. I'd be incontinent if I had that intake, yeah? And a lot of these lads are doing busy jobs, going training, going to gyms, this and that and the other, and so they want to keep themselves stimulated, but that stimulates your bladder. Little word on people say, oh, I'll stop drinking tea or coffee. And they might say, well, I drink green tea now. Green tea is packed with caffeine. That's worse than PG tips in terms of stimulating your bladder. Yeah, if you want a caffeine-free tea, you want chamomile or one of these fruit teas. you do not want green tea, okay? Green tea is good for a number of reasons because it's got a load of antioxidants, but it's got a load of caffeine in as well. Sadly, the other bladder stimulant is alcohol. Okay. There are a couple of other things, okay? A couple of other things that people don't realise irritate bladders. Tomatoes, onions, spicy foods, E-numbers, chocolate. They're my top 5 non-drinks. I know, isn't it miserable? You're amazing. So in effect, they are bladder stimulants specifically for pain. If you're getting pain in your bladder, the best thing to do is be really introspective about it. So if you have a bad day with bladder pain, I know we're going a bit off piste here, but you get a bad day with bladder pain, you want to look at what you've eaten or drunk in the last 48 hours. You do a few of those and you'll think, oh, onions again, tomatoes again. So I had a patient who came to see, because I also have a little bit of a practice in bladder pain. So she was a student at Newcastle University, and she used to come and see me with bladder pain, and everything I tried, and I felt really useless. Every 3 or 4 months she was coming in for a follow-up. It's not the same. Anyway, one day she came in smiling, and I thought something's not right. So she said, I found it, I fixed it. And I said, what? She said, it's the tap water in Newcastle. I said, what? She said, well, every time I go home from university, I'm fine. I come here and I'm not fine. So I went on bottled water and I'm... So the reason for telling you that story is anything can irritate your bladder. It's quite individual to you. So this is why if you're getting pain specifically, a little bit of a diary session, 2 or 3 episodes, and you'll find a common denominator. But if you want to just start cutting things out, then onions, tomatoes, E-numbers, chocolate, caffeine, alcohol, all the fun stuff. Okay, how bad is your incontinence? Well, pad use is a really good indicator. It's not perfect because some patients take a pad off after 2 drops and other people use it to its full capacity. So pad use is not brilliant. But if you take the same person and record their pad use over time, that's really good because the person who takes it off after 2 drops doesn't suddenly then let their pads fill. So that's a really good. We use symptom questionnaires, so we can talk about incontinence associated with urgency, associated with physical activity, intercourse, things like that. How much does it affect your quality of life? That's the key thing, and the answer is massively. And one of the urinary symptoms, apart from incontinence, that really affects your quality of life is getting up at night to pee. And good sleep, and I'm not a sleep expert, but good sleep, as I understand it, comes after you've been asleep a couple of hours and you go into that phase. Is it REM or something? Anyway, that deep sleep phase. So when you go into that phase, that's good quality sleep. But if you're up peeing every 2 hours, you never get to that. So you're tired all the time. So you're maybe not as good at work as you were, and things just start falling to pieces a little bit. So you affect on quality of life. Obviously, after I've taken the history, I'll examine the patient. I'll do a vaginal examination. I'll ask the patient to cough when I'm standing to the side, because from experience. So you can sometimes just see the woman will cough and she'll squirt a jet of urine, and you've diagnosis made then. I also examine the vagina to look for pelvic floor tone. So I'll put a finger in the vagina and I'll say, squeeze tight as you can. And when I tap your knee, let go. Because what's really important about the pelvic floor is not just the squeeze, but also the relaxation. You have to have both, because the pelvic floor has to relax in order for you to pee. There's a thing called urodynamics, and that was what we showed you just now, where you get a tube. I mean, it sounds like a barrel of laughs. So you get a tube put in your bladder and a tube in your bottom. And that allows us to measure the pressure that your bladder muscle generates. We take x-rays at the same time, so it can show us the shape of your bladder, and it can show you the position of your bladder as well. And that's what I showed you just, where you saw that descent when she strained and coughed, and that leakage. That's probably only if first-line treatments fail. So not everyone will have to have this ghastly test, but sometimes urodynamics does give you the answer, especially in a difficult case that's failed a few initial treatments. So you don't need to be worried about tubes going here and there and everywhere, because the vast majority of patients you just need to sit down with and then do a brief examination, and then you've got a plan. Okay, so I'm just going to go through a few treatments for the two types of incontinence and then we'll finish. So pelvic floor muscle training is the first one. Right, this is best done by a specialist pelvic floor physio, okay? Not all physiotherapists are specialists in pelvic floor education. So if you want to give yourself the best chance, you need to ask for a specialist pelvic floor physio. The beauty of this is it's risk-free. There are very little side effects apart from forgetting to do it and it not working. Pelvic floor muscle training will probably improve half of all women with stress incontinence. So, what is the pelvic floor? Well, imagine it like a hammock. And as you can see, it's got some quite important jobs here. So one of them is to support your rectum. The other one is to support your vagina and womb. And the other one is to support your bladder. So there are 3 holes in the pelvic floor. So it's not a great hammock because it's full of holes. And the problem with this hammock is it gets quite slack when that's got a baby in it. And 9 months of pounding and pelvic floor, and suddenly the elastic's gone a bit, hasn't it? And this is when you get prolapse. And you can get prolapse of all 3 pelvic organs. You get prolapse of the bladder, which we call a cystocele. You get prolapse of the womb. You get prolapse of the rectum. So everything can prolapse. And the problem is when these things prolapse, if they don't cause leakage, they often make it harder for you to pee because you kind of got a kink in the pipe. What's your first thing to do if you can't pee? Strain. So let's strain and put a bit more pressure. And so it gets worse. So a pelvic floor physio will educate you in terms of what you can do. And this has got really good results. And we've come on miles, even in my lifetime. So now any woman who delivers should have a visit from a pelvic floor physiotherapist and get told the importance. Now maybe some of you didn't get that, but that's something that's in now. And that we're hoping will prevent a lot of pelvic floor issues in the future. If that probably will help half of all women, so that you've got another half where you have to go on to the additional treatments, okay? And as you go up this treatment ladder, the treatment gets more effective, but it brings with it more potential side effects. And there's a great example of that when we talk about mesh. Right, these are called injectables, okay? So these are the kind of things that almost every teenage girl's now got in her lips. They bulk up tissue, okay? So you can see this is the water pipe, this is the bladder. What I do is I put a camera into the first half of the water pipe, and through that camera I can thread a needle. I can then put the needle into the lining of the water pipe and I can inject these, essentially they're fillers. Now these obviously make that into that, so it's more difficult for you to leak urine down a narrow pipe. So they can be called injectables or urethral bulking agents. They would help 60-65% of women with stress incontinence. The problem is that their effect does diminish a bit over time. And they're not brilliant for women who've got very severe stress incontinence. But I've had some tremendous successes, particularly in women who are too ill to be anaesthetised for these procedures I'm about to talk about. And all I can really do is something under local anaesthetic, and this can be done under local anaesthetic. So that's an option, okay? Right, mesh. So about 15-20 years ago, maybe a bit longer, somebody came up with this this device which would wrap around the water pipe and, for want of a better term, hike it up, make it more difficult for a woman to leak. And this is like a netting, it's mesh, it's made of something called polypropylene, which is a plastic. And this operation replaced the 2 operations I'm about to tell you about, which are a little bit more involved. And it takes 20 minutes. And all the, women were saying, oh yeah, no, we'll have that. We're out of hospital the same day. Oh yeah, I'll definitely have a go at that. Out of hospital the same day. But the problem is, it wasn't properly researched. And it wasn't researched in terms of its long-term effects. Did it stop incontinence? Absolutely it did. Okay, it's a very effective treatment to stop incontinence. The problem is, it brought with it symptoms and signs and complications we wouldn't have even thought of looking at. And they've only come out sort of now. So you might have seen this on the news. Okay, so there's been a big thing. So in 2018, when Jeremy Hunt was health secretary, he was lobbied by a big patient group who said, look, there's thousands of us here and we're all having a nightmare because of this mesh that came inserted. So he said, oh, right, we'll do an independent investigation. So he ordered that in 2018, and the leader of it was a member of the Lords called Baroness Julia Cumberledge. So she wrote a report. It took her 2 years. So she did it brilliantly, actually. First thing she did was to speak to a load of patients. Okay, we were all getting our suits ready, getting ready to be called for this parliamentary inquiry, but she didn't do us first. She did the patients first, which was brilliant, because it got the extent of the problem out there early. She immediately went to the NHS England and said, we need to stop doing this. This is potentially a nightmare. So this is the only surgical procedure in my lifetime. I've been in surgery for more than 20 years. The only surgical procedure in my lifetime that the politicians have said stop. Now, they've said stop to various procedures in various bits, like children's heart surgery in Bristol. They said stop that till we inquire. Across the board, the politicians said stop this right now. And we did. And we've gone back to the operations. And the pause is still in place to this day. Cumberledge has reported, and you know, this may come back, but the problem was we didn't keep, as a healthcare organisation, the NHS and every other healthcare organisation globally didn't keep good enough records, didn't really follow the patients up for long enough, and actually didn't expect to see some of the things we have seen. So a little bit of it in terms of the NHS can be forgiven. But actually, if you're introducing any device, you probably do need to ensure you've got proper surveillance over the long term. And so that's the issue. Anyway, I'm not going to talk too much about mesh because it's banned. But in essence, what it does is I will make it, in order to put some mesh in, I make an incision on the front wall of the vagina. Now, as you can see from the first diagram, if I cut the front wall of the vagina, immediately underneath that is the water pipe. So that's when I put this, which is the mesh, around the water pipe, either side, and it comes out here. So it's like a sling. It supports the thing, and it supports the bladder neck and the water pipe. So you can't have that descent that I showed you on those two x-rays. And that's how it looks from the front. So this is the pelvic bone, as you see, round the water pipe, up and out, just underneath the bikini line. This is an example of one of the problems. So this is a patient, had their mesh put in another place and then came to me with these problems. This is a stone. The mesh is cheese wired through the water pipe, and this is a stone on that. So in essence, we had to take the stone off, open the vagina up again, take the mesh out, and of course there was a hole, and reconstruct her full. So this is, big stuff to deal with these complications. Mesh complications are dealt with in 8 UK centres, and your local one is us. And they're sort of interspersed around the UK, but it's it has been a significant issue. So these are off the table now, but they may come in and they may come back in, but they'll come back in with proper surveillance, and the women will be followed for a long time, and they'll probably only be done in specialist centres. Whereas when they were introduced, everyone took them up. Okay, here's another one. This is exactly the same principle. A piece of material that goes round the water pipe to lift it. Okay, this piece of material though I get from you. So 2 very strong bits of fascia in the human body are the abdominal wall or the outside of the thigh, and you can kind of feel them in yourself, that it's a tough layer. So I take a little strip from so it's a couple of incisions, take a little strip from the abdominal wall, put it underneath the water pipe in the same way, and that gives you the support. That's called an autologous sling, and all autologous means is it comes from you. So this is not the foreign material, that mesh, this is your own tissue, so this doesn't cause a reaction because it's yours. So all I've done is move it from your abdominal wall to support your water pipe. That will be a 4 or 5 day hospital stay. You wouldn't go back to physical activity for 6 weeks. So you can see why mesh was took up. But this is a native tissue thing. To me, this is the best treatment for stress incontinence. This is called a colpo suspension. So colpo is Greek for vagina, and suspension just means lift up. So what we do then is we make an incision here, and we go into your pelvis from the top, and this is what we see, the uterus, the bladder, and the water pipe. This is the vagina from the outside. So we put 3 stitches each side in the vagina, and we suspend it up to these strong ligaments at the front of your pelvis. This is called a colpo suspension. And again, all of these operations are just providing support to the bladder to stop that descent that's associated with leakage, because once your bladder neck goes through the pelvic floor, you will leak. So that's called a colpo suspension. So that's the range of treatments you can have for stress incontinence. The second one is urge incontinence. Again, you can do pelvic floor muscle training for this. And the reason for pelvic floor muscle training is not to support your bladder, because generally these patients have very well supported bladders. It's to provide yourself with the valve that will nip your water pipe and allow you to get the key in the door and get in the toilet. So that's why you strengthen your pelvic floor for this type of incontinence. It's not about support. A bladder drill is a great exercise to do. If you've got urgency, next time you're in all day, and it doesn't matter if you have a few little leaks before you get there, in the safety of your own home, you do a bladder drill and you say, right, how long can I last? So you start, you have a pee, say 9 o'clock, and you start and you say, when will I get desperate? And generally people with urgency and urge incontinence would be desperate by 10. So, right, I've done an hour. Next time, I'm doing an hour and a half. Yeah? After that, I'm doing 2 hours. Before you know it, you'll be holding your bladder for 2 or 3 hours, which gives you social freedom to go around the shops for 3 hours without knowing where every toilet is in Middlesbrough or Stockton or wherever is your shop. And this is really about urge suppression. So urge suppression is just think of something else. The bladder and the brain are really, really strongly connected. So if you're scared or anxious or frightened, you won't have a pee. What do you think? It's a kind of, it's called a fight or flight response. So if you've got a bit of adrenaline coursing, when we were animals fighting each other without the sophistication of modern society, it would be good to be as light as we could be, because we can run away from predators or we can catch prey. So being as light as you can be involves emptying your bladder. So your fight or flight response involves emptying your bladder. And everyone knows that when you get nervous, you think, oh yeah, but I don't have a pee in it. You might go and just do a thimbleful. Mm-hmm. So urge suppression is a really strong thing. Okay. Fluid management. So you do not have to do this, but you do have to realise something that's very, very poorly appreciated by most people. The phrase I hear a lot, or one phrase I hear a lot, is, it goes straight through me, right? No, it doesn't. It goes into your stomach, right? It sits there for an hour. It's absorbed into your bloodstream. It circulates around for a bit. It goes to your kidneys. Your kidneys decide to make urine out of it. What you drink does not go into your bladder for about 3 or 4 hours. Yeah? This is the head thing again. So fluid management. And the reason I say it takes 3 or 4 hours is, so whatever you drink, what time is it now? 8 o'clock, right? Whatever you drink now, you'll be peeing at 11, okay? So let's imagine you like a coffee before bed, or a tea, or a juice, or a hot milk, whatever. You might take that 11:30. That's going to hit your bladder at 2 in the morning. It might well get you up. You know yourself, if you've had a night out and a good drink, and you'll definitely get up to pee in the night, won't you? That's because what you've put in, along with the stimulant effect of alcohol, will get you up in the night time. So fluid management strategies involve patients who and I'm talking about patients who are getting up 4, 5, 6 times, which just sounds unbearable. So I just say, look, after about 7 or 8 o'clock, just stop your fluids. Hydrate really well during the day, but after that, just stop your fluids, and then you might actually get a bit more sleep. So that, in essence, is fluid management. Now, also fluid management is stopping these young lads from doing 3 cans of Red Bull a day. So, or stopping people having, half a dozen cups of coffee, things like that. Anything that stimulates. There are medications. So the medications would be things like oxybutynin is a common one. Tolterodine is another one. Solifenacin is another one. And what they do is they keep the bladder quiet. They stop these little contractions from the bladder that actually are the underlying cause of a lot of urinary urgency, these little contractions. Your bladder should be silent until you tell it it can't be. That's how it normally functions. But sometimes the bladder just develops a little mind of its own and says, I'm not caring what the brain's saying, I'll do my own thing. And the bladder doing its own thing is very often these little contractions. So these pills will stop that. There's another pill that's just out. It's called mirabegron. And what that does, rather than stopping contraction, it promotes relaxation. So in effect does the same thing, but just via a different pathway. Now sometimes you can couple the pills that stop contraction and the pills that promote relaxation and get, a double effect. These do come with side effects. So again, the common thread here is pelvic floor muscle training, a bladder drill, will not have a single side effect. As you go up, the side effects increase. Okay? Finally, we're coming to surgical procedures. Botox. Botox is given to paralyze muscles. So I said to you, the problem with urgency and overactive bladder are these little muscle contractions. But if you put Botox in, so you know Botox is the most potent poison known to man, bar nothing. Yeah? If I put Botox into your vein, you'd be dead in 30 seconds. It's really, really potent poison. The reason people get it in their face is to stop their facial muscles from working, because when your facial muscles work, they crinkle your skin and cause wrinkles, and that's why people get Botox in their face. Now, Botox in your bladder does exactly the same thing. It just stops the muscle from working. The beauty of Botox is you can put it in a certain area, as long as you avoid blood vessels, you can put it in a certain area and it stays where it is. So it doesn't then spread around your body and stop the breathing and all the rest of it. And what we normally do is we put a little camera in the bladder up the water pipe here, so you can see this camera, and through the middle of the camera I can put a needle, and I would normally give about 30 injections, 20 or 30 injections across the bladder, and within about 2 or 3 days the urgency would go. Now, of course, if I'm stopping the bladder muscle from contracting, I'm potentially stopping the bladder from being able to do what it's designed for, which is empty. So about 6 in every 100 that get Botox will have complete retention. So they have to be aware of that risk. Now, if you've got complete retention, there's only 2 things you can do. Learn how to catheterize yourself and pass a catheter 5-6 times a day to empty your bladder, or have an indwelling catheter in a bag on your leg. So you've got to just be aware of that. So this is, what I'm saying is, these treatments get more and more effective to treat the primary problem, but they also bring with them more and more side effects. And it's the case with anything in medicine. The more invasive you become, the more likely you are to get a complication. So the final thing is something called sacral nerve stimulation. So if you wanted sacral nerve stimulation in the North East, you'd have to come to us. I think they've just started doing it in James Cook. So you might be able to go there. And what that does is that modulates the nerve supply to the bladder, because of course a muscle won't contract unless a nerve fires an impulse at it. So if we modulate those nerves and stop those nerves from firing off, then we stop the bladder muscle contraction, we control urgency. The nerves to various bits of the body are not really nicely mapped out. So the nerves to my arms come out about here, right? The nerves to my bowel and bladder will come out here. And this hard bit of bone at the back of my pelvis is called the sacrum. And the sacrum has got a couple of holes in it. And just underneath those holes is where the nerves go through. And they go through from the spinal cord and they go out to bladder, bowel. So we put a little electrode alongside those nerves, and electrical impulses are sent constantly to these, and it just modulates, gives you a bit more control. Curiously, this is a treatment if you can't pee at all, for retention as well as for overactivity. So what we think it does is it gets an equilibrium. So it won't let you go too far one way, i.e. be overactive and want to pee all the time, and it won't let you go too far another way, i.e. not being able to pee at all. So this is called sacral nerve stimulation. It's a very expensive treatment. This electrode is enabled to transmit these impulses by a little implantable battery, which looks very much like a pacemaker, but you don't put it there, you put it just under the buttock. The battery would last for 5 to 7 years and then would need changing. They've just released a rechargeable one that they tell me is going to last 15 years, so once a week you just put a recharger on, or you put a little belt on and walk around with it and it recharges. You know, like one of those phone chargers where you put your phone on the top. Yeah. So that's like the kind of latest technology in terms of sacral nerve stimulation. Just to end, if it wasn't graphic enough and horrible enough, this is the major stuff that we do. So these are my end stage patients. So if they're so incontinent, I've tried all the things that we've talked about and they're still wet, and they come to me and they've got the answer, because they say, just take this bladder out, will you? I don't want it anymore. It rules me. Take it out. Right. Now, if I take a bladder out, I've got to do something with the kidneys. So what I do is this is called an ileal conduit, or a urostomy. So what you can see here is both of the tubes from the kidneys are plumbed into this little tubular structure. This little tubular structure is the length of small bowel. Now you can know you've got meters and meters and meters of small bowel. So I can take a little bit out. I take a little loop like that out, join the ends together so there's no leakage of feces into your abdomen, and I can plumb the ureters in. And this is a urostomy. You will make urine, it'll go into the urostomy and it will come straight out. And that's why you need to wear one of these things, which is a stoma bag. Okay? Now this is a big thing for body image. So that's something that's really got to be talked about. So all of my stoma patients would go for counselling so they fully understand, because what I cannot do is turn back this clock. If I've taken your bladder out and done this, I cannot, that is me finished. I can't do anything else to help you. But body image can be, embraced. So this is a patient of mine who's a model, and she has had a urostomy. And it was a very nice procedure. As you can see, she's nice and thin. And she models swimwear and everything, and the urostomy doesn't bother her at all. But in reality, she looks the same as this fella. She's got a covered stoma bag, but if she was to put a see-through on, you'd still see the same thing, the stoma. So it can be. If you can't tolerate that change in your body image, but you still need your bladder removed, and well, I can do something different. Rather than that loop of small bowel, I can make it into a ball, like a little pouch, and I can take your appendix from where it's normally situated and plumb it onto this new bladder and cut the tail off the appendix, and I've then got a hollow tube. Well, as you know, the appendix has got a valve in it, so that I use that as a continence mechanism. That procedure is called a Mitrofanoff, after the guy who invented it. So I can join the appendix to this new bladder, plumbed into the kidneys, and this is the cosmetic. So this girl walks around with no stoma bag on, because the valve in her appendix stops that thing from emptying and leaking out. She then would have to catheterize that 5 or 6 times a day. But as you can see, cosmetically, it's not a bad result. When you compare it to what a stoma looks like, it's not a bad result. So that's called a Mitrofanoff procedure. About twice a year, I'll have to put one of these things in. So this is called an artificial sphincter. This is for patients who can't entertain the idea of a stoma. They don't want to be poking plastic tubes through their abdominal wall. They want to retain their bladder, but they just want it to work. So this is a little cuff which I put around the water pipe filled with fluid. And that squeezes the water pipe almost like kinking a hose pipe, so you don't leak. I then attach it to 2 components. One is a reservoir of fluid, which sits in the abdomen, and the other one is a little pump which sits in one of the labia. And what happens is when a woman has a full bladder, she'll squeeze the pump in the labia. That will let the cuff go down. She'll be able to pee, and then the cuff will inflate automatically itself. So she will, in essence, have normal peeing. So this is at the very, very difficult end of the spectrum. But what I wanted to include is just to show that you've always got options. If you're prepared to take the side effects from an operation, or the change in your body image, or the buy-in from this, this is worse for men, because in men you put the pump in the scrotum. So they can't be standing at the public toilet and fiddling with their scrotum. So they have to find a cubicle, but women have cubicles, so that actually women quite like this. This would be one of the primary treatments for stress incontinence in France. But in the UK, the uptake, in the UK is about 20 done a year, which I do probably 2 of them. So, it's not something that we do a lot of. Whereas these things I will do very regularly. So I think that is everything incontinence and UTI. So if you've got any